Now today, glad to have people back in Greenspun Hall for live events. Yes. And glad to talk about how we can grow the healthcare economy. For those who don't know me, my name is David Demore. I'm the intern executive director of the Lincy Institute, Brookings Mountain West, and I also moonlight as the chair of political science on this one. So if you don't know about the Lincy Institute, this is a little information about us. We essentially conduct and support research and economic development, education, governance, health, nonprofits, and social services with the idea to build capacity for the region. Much what we're going to do today is very much what we're interested in doing here. Before we get to the event, I wanted to spend a couple minutes just sort of talking about where we came from and how we got here, because it's been quite a journey. Obviously, in hindsight, we might look back and say, of course UNLV has a medical school. Of course it has a state-of-the-art privately funded building. Well, how else would it have happened? Well, we'll talk a little about that. So, 2011, coming out of the Great Recession, Nevada commissions Brookings Mountain West, and SRI to conduct an economic development analysis. Essentially, how can Nevada rethink its approach to its economy here? One of the key recommendations here is targeting specific sectors and then mapping those to the state's regions. In Southern Nevada, what jumps out? Healthcare, right? There's two key points here. The first is this one, is that Nevada is essentially exporting its healthcare, right? It's not doing enough of its own healthcare here, and we're nowhere near the national average, right? The second thing is this is putting our big metro, Las Vegas, at a severe disadvantage relative to other U.S. Western regions, even smaller ones which have their own ability to do their own healthcare here. So, just like that, the state jumped on oh no, that didn't happen. Started the conversation, and it was not a conversation necessarily about better health outcomes, it was a conversation about economic development. But even this was not necessarily well received. If you were at the event 2 weeks ago, you heard Lindy Schumacher talk a little bit about some of the hurdles that had to be overcome. When we were digging through old files for this, Bill Brown came across old email exchanges 4 or 5 presidents ago, being pressured not to pursue this here. This is one of our favorites from the Reno Gazette-Journal about this idea of how ridiculous it was to even think that Southern Nevada should have its own medical school. So my predecessor, Rob Lane, found old Paul Umbach and company here and said, well, how can we make the case to get this idea moving here? So they commissioned an economic impact analysis of what a medical education would bring to the region here. And a couple of key recommendations here. At this time, the idea was a standalone medical school or some sort of joint partnership with UNR's campus that was down here. And they said essentially a standalone medical school will generate a whole lot more money. And they estimated by 2030, a standalone UNLV medical education, medical school would yield $410 million. We're gonna hold you to that, Paul. You got 5 more years. Or 7 more years. We're almost there, all right? So this sort of changes the dynamics, put some real numbers on it, get a sense of what's going on here, but still, right, the regents approved the idea in 2014 of a UNLV medical school, then we gotta go fund it. And so going back to 2015 in the legislative session there, the request was $27 million to start the UNLV School of Medicine. The governor's budget had about 1/3 of that in there. The regents and the then chancellor were more than willing to push this whole idea back a year, the start of it, which would of course have all kinds of implications for accreditation here. But where there's a will, there's a way. And in this case, there was a fight between the taxi authority, the taxi drivers and Uber coming into the state here. And Michael Roberson engineered essentially a tax on ride sharing to make the budget whole for the medical school back in 2017. And then all of a sudden, the medical school was able to launch here. At the time, Lincy had gone back to Tripp Umbach and said, hey, can you redo your analysis? Something that we can take the legislature to show what, if we don't do this, what are the implications for the state's economy and of course, regional healthcare assets in Southern Nevada there. And then, as was expected, philanthropy jumps on this, right? One of the sort of main arguments for pushing the UNLV School of Medicine was there was a lot of pent-up philanthropy that was never going to go to medical education as long as UNR was in charge of it. And so what we saw the community was essentially funding full tuition scholarships for the first class. Coming out, no debt, but also this ensured, this is an important part of this, is it ensured that got a really good first class, right? Because that would allow then essentially for accreditation 2 years later to occur. So this is a very, very important component to this. Then the building. Lots of efforts to derail any medical education building. So we go back to Tripp Umbach and say, what's going on? What's the state of play in terms of medical education buildings here? And they come up and essentially do an analysis of what are sort of the best ideas out there, what's the future of medical education building going to look like? And it wasn't what was being proposed at the time there. Still, nothing happens. 2017, Brookings Mountain West starts thinking a little more creatively. How can we do this, get a sort of a work around the state? One of Rob Lang's specialties was always figuring out a way to get around the obstacles. In this case, it was the creation of a development corporation, the Nevada Health and Bioscience Corporation. Late 2019, Governor Sisolak announces that the Nevada Health and Bioscience Corporation will plan and construct the medical education building using $25 million in state money and $120 million in philanthropy. So where are we? Well, first 2 classes completed their MDs. All right. 42 of 116 residency matches for UNLV grads are located in Nevada. So this will be a fact sheet that will probably be out tomorrow. Just finished this up this week, doing the comparisons, trying to create some benchmarks on the residency part of this build out here. Comparison to the UNR School of Medicine, how many are staying in Nevada? You see there about 14%. We're dealing with 36% of our residency matches from the UNLV School of Medicine are in Southern Nevada, which also means 2/3 are leaving. We do know, of course, that if they stay for the residency, they're more likely to stay for their careers on that one there. Accreditation. Name change to recognize the biggest donor to the Nevada Health and Bioscience Corporation, the Kerkorian School of Medicine. Medical education building opened, well, had ceremony 2 weeks, moving in November, right? Under budget and well ahead of schedule. And we're also seeing the build out, of course, of the Las Vegas Medical District through a mix of private and public investment. And at the opening of the medical education building, Governor Sisolak announced legislation to create the Las Vegas Academic Health District, something we'll talk about in the panel component later. So where are we? Well, we still continue to lag. So during the recovery, Brookings Mountain West had the opportunity to work with GoEd and SRI on a sort of the recovery and resilience plan. One of the things they did was sort of benchmark those target industries and looking at the growth. The good news is the healthcare sector has grown, but so has the population. So we're working really, really hard to sort of stay in place there. Last spring, we put out our post-pandemic policy recommendations, and a lot of that focusing on the academic health center, building up medical capacity as the sort of straight route to developing and growing our region's economy there. If you look at the top tier UNLV plan, it prioritizes the UNLV Academic Health Initiative, right? Through some of the federal money, the Nevada Health and Bioscience Corporation will manage the public health lab and the ambulatory care facility. In the NCHI budget request is $9.2 million to expand the class sizes to 60 to 90 and eventually, hopefully to 120. And of course, to integrate health education. This is the 4th rated priority in the budget for new funding. And we go back to Tripp Umbach and say, Paul, we need you to come back to Las Vegas. It's been a couple of years. Come back in, tell us what we can do with an academic health center. Now I'll turn it over to Paul Umbach, president and founder of Tripp Umbach.
Well, thank you very much. tired of hearing about all those studies. We're so happy to be here. I want to thank everybody for coming today. I have a couple things to start with. The first thing is what an incredible accomplishments you've all had here in Las Vegas over the past 10 years. And it is an amazing thing to see not only what David presented, but just to drive around and to look at the new medical school building, to see all the activity in the campus here, but also in Shadow Lane, to see the development that's happening and the energy that's in the medical district and in downtown Las Vegas. And this is the kind of start, and this is the kind of fuel that's so important to grow an academic medical center. And today, my presentation really has two purposes. One is to give you some numbers that shows how the UNLV academic medical programs and how the entire academic medicine industry or ecosystem is doing compared to other markets. And the other thing I'm here to do today is to give some recommendations and really inspire some conversation with our illustrious panel, which includes the leader of economic development for the region, the dean of the medical school, and of course, the president of the university. And they'll be all introduced separately in just a little bit. I've been around a long time now. In 60 years of life, I've been able to be a consultant for almost 40 years of that. When I was about 20, I stopped having jobs and was involved with academia. And then from academia, I got involved with consulting. So I've never really had a job. In fact, my last job I had a paycheck with like an employer was 1986. And it was to be the director of economic development in Elmira, New York. And that job lasted 2 years. So I've been working on my own, but with a great team. And the Tripp Umbach team has been in all 50 states, 500 markets. We've been in about 20 different countries. And we find a way to do 50 to 100 projects a year. And we've been doing that for a long time. So we have a couple thousand projects that we've worked on. One thing I really love as I think about where we are as a company and where we're going is so many of the things we've touched and so many of the projects have done so well. And this is one of the ones we're the most proud of, because if you go back to what David just took us through, there were some challenges here to get academic medicine in Las Vegas off the ground. There were challenges 20 years ago in Phoenix to get academic medicine off the ground. Yesterday, I announced the newest LCME medical school to be approved in Compton and Watts in South Los Angeles. I started working with Charles Drew University 16 years ago, and the baby finally came out yesterday at a big ceremony in Compton. And it is the 4th HBCU medical school in the country, the last one in 40 years, and the only one west of the Mississippi. So there are certain projects, and we always put the work here in Las Vegas for UNLV and for Lincy high on that list when you look at the amount of projects. We've been involved with 30 new medical schools, and we've been in about 100 academic medical centers over our history. And they include the whole range from the biggest and the fanciest to the ones that took a little while longer and to the ones that are needed the most. So if you look at the ones on the short list of the ones needed the most, you're right at the top of that list. And that's something I'm really proud of in my career, that we were always, it seems like, in the place where the need was the greatest, and that's how it. I want to recognize my friend Barbara Atchison, who is the founding dean. Give her a round of applause. Barbara comes from Kansas City, the same place I come from now. And when I think about the folks in this room that have come, and one other mention, and I know it is always so bittersweet, but my brother in this and one of my best friends in this was Rob Lang, who passed, as you know. And he was the best urban geographer in the world. And I will tell you that I just loved the time to talk with him, and he inspired me a lot. So that's enough about us. Let's get on to the findings. Well, first of all, to do any kind of findings and analysis, you have to have something called a methodology. Oh, now you're all going to fall asleep. The students are like, no, he didn't say methodology. Well, I did, because we picked 9 public medical centers west of the Mississippi that are aspirational peers in some way, in that they've been around a lot longer. And you see Oregon, Arizona, Colorado, Kansas, Nebraska, New Mexico, Oklahoma, Utah, and Washington, the University of Washington. Each of these have strong teaching hospitals. They have large residency programs. They have pretty substantial NIH funding. They're the fully functional, mature academic medical centers. And later you're going to see how they compare, and I'm going to give you a lot of information and data on them. In the lower part of the slide are the new ones, the new 5 academic medical schools that are around the country. And you have the Phoenix program, which is different than the Tucson program. They're a separate medical school. El Paso, the Austin University of Texas New Medical School, FIU, and the University of Central Florida. I've had a chance to work with each of these, and I think almost all of the peers. So I have a good understanding of them. I actually live walking distance from the one in Kansas City. I walk my dog past there some nights. So the thing we're doing with this methodology is doing a lot of benchmarking. So if you like benchmarking, you're going to love this. If you don't like benchmarking, stay tuned. We're going to get into a great panel discussion where there won't be benchmarking. First of all, as any physician, when you first go into the consult room, we have to take temperatures and blood pressure. We need to know where you are. So one of the things I was really happy about this project is I got to do a little bit of temperature check and blood pressure check on how well you're doing on that $400 million economic impact by 2030 that the medical school is going to be. And for these data, the 460, boy, I could make it look like you got there a lot faster, couldn't I? But the 460 is the economic impact of everything related to health science and medicine at UNLV. And that includes the residency programs. It includes dental, mental health, nursing, and the medical school. But it's a big number. There's already, if you look at the total economic impact of UNLV, you can see a sizable percentage of it is in the health science and medicine part, and it's a growing part. And with the work that you all have been doing at UNLV, this will continue to grow. If you look at just one of the major medical providers, UMC, and UMC's economic impact at $800 million is not just the hospital or hospitals, but it's their whole clinic and public health infrastructure, because you remember they are the safety net and the county hospital. So when you add those two together, you get to about $1.2 billion in economic impact annually. So the way this works is that's direct, indirect, and induced within the region, within the county or the metro. And then we also measured other Las Vegas Medical District partners. Those would be folks like Valley and the other institutes, the Neuroscience Institute, and some of the other medical and healthcare players. That number is going to grow dramatically. So what you're going to see is that 1.7 billion in economic impact coming out of that district. I predict in 2040, by 2040, will probably almost double. And the reason being is that there's so much already being planted there that I know from benchmarking over 30 years looking at all those other markets, you've planted a nice crop of things that are going to do really, really well. And what's also going to make it work really, really well is you have a growing, prosperous region. So the region itself will drive a lot of growth in bioscience, in research, in economic development. So this is this picture of where you are now. Okay, now for the fun part. Remember that number, 1.27 billion? Now you get to see how that number stacks up against the established academic medical centers. And you can see that the big one is the University of Washington, and they have about 500 million in NIH alone. That university probably has $1 billion in total research funding. They have a large residency program. They have a very, very large clinical footprint that goes into multi-states. But then you can see some of the other ones like Oregon. And so if you go back to UNLV, if you go down to Nevada, this is the teaching hospital at UMC pushed together with all of your education, research, and clinical. You can see that you're about half as much as Albuquerque and Omaha and Kansas City and Oklahoma. And then you're about a third as much as Utah and Colorado. And then off the chart is really Washington and Oregon. When you look at that, you think about two things. The first thing you think about is we're on the chart. We can be measured now against established academic medical centers who have been there 50 years or more. Think about that. I mean, if we were doing this presentation 10 years ago or 20 years ago, we wouldn't even have you on the chart. So that's the takeaway from this slide. Now, how do you stack up against your peers, the ones that were starting? And in the full report, we have a lot of notes, like what year did each of them graduate their first class? What year did you graduate your first class? I'll be a spoiler alert. You're the youngest, okay? And your university is also the youngest, or one of the youngest. I think you and FIU compete for who's the youngest. You're in a market that hasn't had a lot of academic and healthcare economy. So you're kind of starting, you're new seedlings out there. So if you look at it, who's doing the best? Well, look at orange, and you'll see that from an academic medicine perspective, remember our old friend, the 4.6 billion? There it is right there. Well, it compares very well with Texas, El Paso, and Texas. And when it comes to the academic medical center, from a research, healthcare, from a research and education perspective, you stack up pretty well with the other newly formed academic medical centers. And you do find when it comes to the clinical footprint, if we would combine the UMC plus the other forces. What I'm really trying to say is your academic medical opportunity in the Las Vegas Medical District seems to be really, really well positioned compared to some of these other markets. I mean, look at how small the healthcare component is at Florida International. They don't have a healthcare partner. And even when you look at Texas Dell Medical Center, they have a very small hospital partner. And at University of Central Florida, the small HCA partner is very small. So when you start to combine what you have here and create an academic medical center, this chart shows, key finding number 3, that you're going to be in a good position among the peers. Well, what drives all this economic impact? Now, I'm going to throw you way too many numbers. I want to just have you focus on two things. So the first thing I want you to focus on is the numbers on the right are NIH funding. And that doesn't mean that's all the funding they get. It's about 2/3 of the funding that a medical school usually gets, okay? But it's a good metric. And one of the nice things about the NIH data is it's really good data, and it's down to the penny, and it's apples to apples. These are all the medical schools. This is all the universities. What did these universities get in NIH? And that might not only go to the medical school. That's my university, UNLV, got X from the NIH, National Institutes of Health, and UNLV got $9 million roughly, the last data from these data, okay? That's small compared to the others, okay? And when you look at the new ones, it's small, but it's about the same as Central Florida and more than Texas Tech or University of Arizona, Phoenix. And you might say, why? Wouldn't Phoenix be way bigger? Well, most of the NIH research goes to Tucson. And you might say, I'm surprised El Paso is so low. Well, that's because most of it goes to Lubbock in the Texas Tech system. But you're in a situation here where you have great opportunity. Now, Florida International in Miami has actually got their NIH research up to 30 million now as a university. One of the reasons for that is that they were one of the older in that group of young medical schools, and the folks at FIU have really pushed that. But why have they pushed that? And how did they push that? That might be the rest of the story. They went to their state and to their philanthropists, to their partners, like you folks have done, and they've said, we've been around now for 10 years, 15 years. We want to now take research to the next level. So FIU might be one to follow in terms of how they got their research to grow. Now you got the other driver, and that's residency programs. Residency programs are a great indicator of how strong the healthcare delivery system is, how much subspecialty and specialty care is in the system, how many programs are growing within academic medicine. So a good indicator is how many residents you have. And you can see that the university hospitals in our sample, we have UMC there with 508 beds. So it's about the size of a lot of the academic medical centers. So it's not an undersized hospital and delivery system. Actually, if you look at their whole delivery system, it's a pretty robust healthcare delivery system. The number of residents, 212, is far below, but not that much below, Banner at Phoenix, Nebraska, Oklahoma. So if you look at those numbers, there's some good news here, and I don't know if all you know this, but there's been a state program to help grow residencies that just got started in the last couple years. And I think that that number, not just at UMC, but at UNLV-sponsored residencies can grow. I see opportunity here for the economic impact of the healthcare delivery system to continue to grow rapidly as research grows and as residencies grow. So I'm throwing you two things that need to grow, and I think that you can have good success in both of those things as I do my analysis. So now we get into quality. Now this is not the happiest part of the presentation. The quality of the hospitals in Nevada and the quality of the hospitals in Las Vegas lag behind that of others. And these are data that are from the Centers for Medicare and Medicaid Services. These are the star ratings that you probably saw some of this in the newspaper. I'm sure there were stories done that Las Vegas had the fewest number of five-star hospitals. Nevada only has one five-star hospital rated, and it's renowned, and it's in Reno. And then you have the number of one-stars. Nevada had the most in the one-star. So almost all of your hospitals in town are either 1 or 2 stars. So what does that mean? Well, it means two things to me as I look at this chart. That means that people generally don't travel a great distance to go to a 1-star hospital in quality. They travel a great distance to go to a 5-star hospital like the Mayo Clinic, the Cleveland Clinic, Johns Hopkins, UCLA Medical. They'll go to those for distance. So people will say to me a lot of time, Paul, I have a great idea. Let's just be a destination for healthcare. And then we'll solve all our problems because we have great airport, we have places to stay, we have places to eat, and that's all we need, right? Well, you also need great quality healthcare to get people on a plane and bring them here. And one of the reasons why so many people leave this market to go to UCLA, which is a 1-star hospital, is because they know the quality is going to be better. So there's work to be done in the quality of healthcare in Nevada, coming from the bottom and raising that up. And how do you do that? So if I don't tell you how to do that, I've kind of ruined the whole opportunity here in this presentation, because you might say, well, there's nothing we can do about this. We're always going to be 1-star. No, residency programs, clinical translational research programs, partnerships with public health and community health, partnerships in an integrated academic medical center to look at patient outcomes and population health improvement, quality improvement as a team. Now we're starting to see that many of these same recommendations will help us on the quality side. So I don't want to get too quick to the finish line, but I'll tell you, without the things we're talking about, I don't see these scores changing very much. And if these scores don't change, your opportunities to keep people in the market for care or to attract people from outside the market for care are probably not going to be very well received, and you'll be caught in this low ranking for a long time. Now we're going to look at the markets. This is really where we start to think about what Tina and others look at, which is market by market. Who are you competing with, and how do you do? And these, I know you're nodding, because these are all your people usually compete with. Well, let's look at their economies. What these data show is the percentage of the economy of jobs. 21% of the jobs in this region are in healthcare, higher education, or education in general, and science and technology, scientific and technical services. That's 1 out of 5. 1 out of 5 jobs. And you might say, well, that sounds really good. 1 out of 5 people are employed in healthcare, higher education, technical and scientific services. I'm sure we do well. Well, look at Seattle. Now, Seattle's an outlier because the amount of people in science and tech in Seattle is off the charts. So we're going to throw them out. Sorry, Seattle. But if you look at the percentage of people that are involved with healthcare in Seattle, it's not that much different than Las Vegas. That's interesting. And if you look at the percentage of people in higher education in Seattle, 9.9, that's not that different. In fact, the winner would probably be Salt Lake. If you look at Salt Lake there in the middle, if you take healthcare and education together, they're a good market in both. And you might find that as you look at other data there, that what's really hurting Las Vegas right now is really the technical and scientific type jobs. If I showed you Pittsburgh, my hometown, you'd see that 45% of people are employed in those sectors, and the number in the research and technology field was about 10% just by itself, or 15%. So now, you know the drill now. We're going to show you the new medical school markets. Are you all ready? These are the established markets. This is where Nevada falls, Las Vegas falls. Well, you're last again, but you can find here that if you throw Austin, if you take the science and tech part of Austin away, and we all know that they're a major tech center, and Seattle's a major tech center, and there's also a lot of research and development in that, you start to see that you're really very similar in the academic medical part, healthcare and education, to Miami and to Orlando. And Miami and Orlando are similar markets. In fact, if you had to find a peer market, it would probably be Orlando. If you had to pick one, who are we like? We're probably like Orlando. But Orlando has a little bit more going on with the research and technology and things. And then when you get to El Paso, it's even smaller on the technology and research side than you all. So what is this telling us? I have to, every time I do a slide, you have to say, okay, so what does this slide mean? This slide means that you're well positioned against Miami and Orlando. And I would say your aspirational market is Phoenix. If I go back up to this slide, you're well positioned. Your aspirational market would be Salt Lake, okay? You can pick any of them you want. You could say our aspirational market is Omaha, but who wants to pick Omaha as your aspirational market? I don't know. Omaha's a great market. Warren Buffett. I love Omaha. I've been working in Omaha for 30 years. It's a great market, but nobody wants to say it's aspirational, okay? Salt Lake, well, there's Park City close by. It's a great market. It's beautiful. And so I would say Salt Lake here, and I would say Phoenix. Now, why Phoenix? Why is it always Phoenix? Well, because people that study this, like my friend and our mutual friend Rob Lang, who studied this his whole life as long, we were the same age, so he studied it as long as I studied it. He just studied it better. Will tell you that we're tracking pretty much what happened in Phoenix here. And I would love to say that ASU is the aspirational university for UNLV. And FIU is a little bit ahead of the game as an aspirational university, and University of Central Florida. So we start to think about that as aspirational. Whether you want to be like Austin, look, I don't think Austin's where I want to be in terms of healthcare and education services. I think they're a dog when it comes to that. The only reason they're on this list listed there, if I took the blue away, they'd all be pretty similar. Okay, so now we're going to get to numbers. I have a mistake I have to share with you. And it's not a mistake in numbers. All the numbers are right. It's a mistake in my communication with my team. I said to my team, I do not want to have a slide that has all those numbers on it. What I want is I want a graphic that shows how UNLV's medical school, health science programs, UMC, and the Health Science Center and the partners will grow from 1.7 billion to 2.4 billion to 3.6 billion. I was very clear about that. I said, please do not give me this chart. I want a bar chart that shows everybody that you're at 1.7 billion, following along. You're going to go to 2.4 billion by 2030, which has the medical school at 522, which is a little bit juicier than we thought. And then by 2040, you'll be in the range of 3.6 billion is where I expect an academic medical center in a community of 3 million people to be, which you will be at 3 million people by 2040, and it all works.
2040 doesn't add up. That's wrong too. Maybe it's 6.3.
Oh, no, it's okay. Well, that's why we changed this slide. We're going to move on to employment. Thank you, Mark. When you get to, and you can see what I was wanting to do as the presenter. I wanted a nice bar chart to show people, and I got numbers. Well, when it comes to jobs, we haven't talked about jobs yet. The total employment in the region related to all of these entities is about 10,600 jobs. So you might say, okay, all of this academic medicine ecosystem. All right, so we're going to move on. We're going to go to taxes. A lot of taxes. We're going to change this.
That doesn't work either.
Okay, let's go to what's driving the economic impact. I knew those were bad slides. I called Julie this morning and said, I don't like those slides. I told you to get rid of them. When we look at the economic impact of the physician workforce, so much of the economics in medicine is not while you're running a school. And it's not while you're training doctors in a hospital or clinical setting. So much of the economic impact is the economics of physicians going into practice and staying in the area. And when you have such physician shortages, in a sense, you're having an economic development deficit because you don't have the folks out there. And when people leave with billions of dollars of healthcare spending and end up in Los Angeles with those dollars, as we always said with those earlier reports, you see billions of dollars leaving, which should be spent and respent here, and leaving the market and going some. So those dollars are actually flying away with people. And if people aren't coming here for care, you're not getting those dollars coming back in. So doctors actually have a significant economic impact. And if we can get to, by 2040, 120 physicians trained, and right now, I think the goal is to get to 90 per class from 60, and that's a great goal. And maybe by 2060, 2040, you can also see that every physician that practices in an underserved area, and you might say, where are the underserved areas? Well, if you look at the map, pretty much everything's the underserved area. So if you're looking at healthcare cost savings, you're looking at each physician each year generates 3.6 million in cost savings. And so a lot of people ask me, what does that mean? How do you explain that? How do you measure that? What does that mean? Well, it means that if you don't have a doctor and you only have the emergency room or urgent care, you're going to actually present for inpatient care at a much later state. You haven't had much, or you're going to say, I don't even want to go to the emergency room. I'm going to wait longer because I don't have a primary care doctor. And now when you finally do end up going through the ER into care, the care is so much more. And there's a million examples of that. It can be diabetes, it can be any chronic health condition. You'll see that the cost goes up so much when people delay care. But if you don't have a primary care provider, how will you get that early detection and innovation? So this starts to add up to about $84.4 million if 20% of the graduates practice in Southern Nevada in an underserved area. You can double that number if 40% of the graduates. You can triple that number if 60% of the graduates. So we start to see that not only do we have economic impact that comes from physicians in practicing in the market, we also have cost savings and improved health. So I'm going to give you some recommendations. And the recommendations come from my experience working with about 100 academic medical centers over my career, and it also comes from my experience in all of the markets we've talked about on the new medical schools. And I think the first thing really is to align more within the medical district between UMC and UNLV. And also further than that, to also align then with the other, and I know this is already happening, but I'm going to recommend here really an integrated academic health center model. And I know there's work that's being done in this. I know that Dr. Khan, who's going to speak soon, has been pushing that, and that'll be a good question to ask. I know there's foundational work being done, but it's not even to connect what UNLV has in that first cluster or ecosystem. It's actually from there to then connect with UMC, Valley, and all the others and create this integrated academic health science center, and even greater to connect with public health at the county and the state level, and even greater to connect with economic development and different kinds of workforce initiatives. So you got all these different things that have to come together in this ecosystem. And the regions in the US that have done the best at this have done that. They've created that very tight collaboration between all the players, and that's a really important thing for us to recommend. It's really going beyond just building the university's team. It's really connecting, and that's a lot of work to be done on that. The second recommendation is to rebrand UMC and probably all the other players that want to be in the rebranding as the University of Las Vegas, Nevada Medical Center. The UNLV Medical Center really would help create kind of a there for the rest of the world, because right now it's very scattered. Where is the teaching hospital? Well, there's a few. Where is the university? Does the university have a medical school? Well, it does now. If I came here to do research and innovation, what door would I knock on? If I want to do clinical trials, would I go to, how many doors would I go to say, could I use you for clinical trials? So this next level up is really to create this. And if you look at the top-ranked hospitals in every state, you'll see that the University of Kansas Medical Center, the University of Nebraska Medical Center, University of Colorado Medical Center, Oregon Health Science University, University of Utah Health, and University of Washington. In almost every state, the top-ranked hospital is branded as the University Medical Center. And you might also know that if you look around the country, most of them are not fully owned and operated. Okay, so the University of Pittsburgh Medical Center, which has 90,000 employees and a $22 billion budget. It's a little bit of the University of Pittsburgh. It's a lot of an independent health system. It's a little bit of a research institute or something. It's touched a little bit on some other collaborative partners. So the University of Pittsburgh Medical Center is not the University of Pittsburgh. It's part of the University of Pittsburgh, but Pitt is probably a small percentage of that $20 billion enterprise. And if you go to the University of Utah and you say, well, who's the big hospital there? Well, it's not owned and operated by the University of Utah. So I feel that if we start to look at how we brand the university, one thing that is universal is UNLV, and then each of the parts can be part of that. So that's a recommendation that I give you. Now, this is the recommendation that we rehearsed earlier in our rehearsal, where Bill says to me, your plane is about to leave. And just like I fast forwarded through slides where the math was wrong, when I put out a recommendation like rebrand UMC as UNLV, this might be a time for me to get out of town. And then the other is to expand the high quality clinical services to diversify the healthcare workforce. And I really think that this goes hand in hand with the other recommendations. We have to work on a system of quality care. I don't think it's fair to the hospitals, especially the charity and safety net hospitals, to say, you're on your own, UMC. I see you're a 1-star rating again this year. Good luck with that. Hope you get to star 2 next year. No, the medical school, the faculty, everybody in this room has a stake in getting those star ratings higher because we're all part of this. And that's that virtuous cycle that I'm showing where we can start developing a stronger healthcare delivery system. And then expand research programs. How do we do that? Well, I think the state has to step up and be part of that. You know, UAB, University of Alabama, Birmingham, was a also run player. They were average. When I first got involved, even in the late 80s doing this kind of work, they were on the list, but they were really high on the list. And the state of Alabama and the folks in Birmingham said, we're going to change that. We're going to spend real money recruiting real investigators that can come to Birmingham from all over the country to start their research programs and bring their NIH money with them. And I think one of the strong recommendations today is to say, we need to start playing ball and getting investigators from Boston, which is very expensive and very crowded, and the weather's not good, and from Philadelphia, all 3, plus it's dirty. And then I love Philly. All right. And then from San Francisco, where it's all of those things and cloudy, and to say, let's come here and make that investment. And it's very expensive. But the $9 million you have right now in NIH, this is sad to say, is not organically going to turn into 50 or 200 anytime soon. You're going to have to buy researchers and money for their labs and bring people that have money with them, and the state and the region is going to have to make that a priority. And then you're going to start to see 50 million every year from the NIH, and then 50, and then 80, and then 150. And you'll start to get up into the tiers you need to, but to say, well, we have our little homegrown NIH program, let's try and grow it to be 200 million, none of us in this room will see that. But if we start to say like UAB did, so an aspirational peer might be UAB in terms of doing that very well. I think this is my final recommendation because they never give more than 5, and that is to continue to grow the residency training programs. You already have a start. There's opportunity here to grow more. This is a can't miss opportunity to create the specialty programs, the trauma programs, the transplant programs. And you know what? Any program that you want to have, if you don't attach graduate medical education to it and fellowships and residencies, that program's not going to do very well because how are you going to re-engage the faculty of the future? How are you going to get the doctors to stay in that program? I do have 6. Oh, this is where you come in, my friend who's going to be on the panel. A biomedical economic development strategy, an effort to grow the biomedical economy. Remember that small little percentage, 5.5, that was woefully low compared to others? There's got to be an effort, too, for the private sector and the public sector to come together to grow the kinds of bioscience and economic development. And to say to those companies and to those startup companies, we have a there. We have the UNLV Medical Center, and it's part of this academic medical ecosystem. And it's at the Nevada Medical Center. And here's what we have going on there. Come and bring your bioscience business. Come from Southern California and Boston, where you can't afford to be in this business, and come to Nevada, where we have a growing bioscience economic development area. I'd love to market that as long as all these pieces are in place and you're building the rest of the story. So my friends, that's all I have except for a lot of words on a slide that I also said, don't give me a lot of words on the slide. At least these words are not math and they add up. I want to thank you for your attention and for listening to this presentation. I want to give you all a round of applause. You get a star for staying awake during benchmarking, and I give you to Bill Brown, my friend.
Paul, I'm going to ask you to do me a favor. Those slides you don't want to show,
Yes.
could you go back to them? Because they're not quite incorrect, but they are poorly labeled.
Oh, and I know why, because they're additive.
Yes.
Okay.
If you see the first three numbers add up to the fourth,
These numbers add up to this.
and those two numbers add up to the third.
sorry.
No, you're correct. We need to point that out.
These three numbers, and you know what, if I was more on my toes, and if I would have actually generated these numbers and didn't own Tripp Umbach, but actually did the work, I would have known that. And notice how quick I was to accept fault and to pass blame to my coworkers. I accepted fault and I passed blame. Yeah, the numbers do add up. Thank you. Because we published a lot of these numbers already, my friend.
Yeah, so we'll enhance the labeling.
Thank you. And we're going to have a lot of time for questions and comments as the panel comes up. So thank you.
But I do want to thank David and Paul for their remarks, because they took us through a quick history, or not so quick if you had to live through some of it, I suppose. But I want to point out that our panelists have the advantage of not having had to deal with most of that. President Whitfield, you came and joined us in summer of 2020. I think, Dean Kahn, you were about a month or two ahead of President Whitfield, so only about 2 years. And of course, Tina Quigley's been around our community quite a bit, but in her new position only since February.
February, yeah.
So less than a year. So they're going to have a whole different perspective than these old guys that you heard talk before. So at the risk of starting a free-for-all, could I just ask, was there a statement, a number, something you saw that you're going
I was
to...
so happy that we were the 5th worst. I thought for sure we would be the worst when it came to the hospital care. So I'm so curious to know who those other 4 are. I'm going to throw them in my presentation.
They don't have medical schools. You used to be at the bottom.
I'm
You've
still-
actually come up from last.
We've come up from last, so.
You're on your way up.
Okay, so since you guys got here, we're on our way up.
I just want to say, Paul, I'm from Philadelphia, where I met the founding dean when I was a first-year medical student. We won't say what year that was, but it's not that dirty.
Pittsburgh's not that smoky.
Yeah.
President Whitfield? Anything
Oh,
jump
is
out?
that what he got away with?
We'll go back to him.
You know, I am a data guy, so I just absolutely absorbed this. I love this presentation. You know, there's pieces of it where I was like, boy, it's going to be hard to get there. And then there's other pieces of it that's like, we're on a pace to blow right past that. And, you know, some of it is just the secret sauce that seems to be going on. UNLV has a lot of momentum. I think it's in part too because we have been focusing on being better connected to the community in virtually everything that we do. And most importantly, there are leaders like Tina Quigley who actually, we have much more robust conversations. We have much more of a view towards what we really need to be doing in the future and being maybe even a little bit more focused in some ways. We are and we're not. I keep thinking that I am, but I'm not. It's like I want to do everything. I want us to be able to do everything, but there's certain things that we are really focusing on doing well. And I think for in the healthcare sector, it has been Dean Kahn who has built on the foundation that was left to him to be able to try to keep those relationships going. And so while you said, you know, we're newer, and so we didn't go through all of that, believe you me, we feel the anxiety, the trauma that was experienced by it, and we have a great appreciation for it. And trying to figure out how we can actually make sure that we lead and make some of these numbers more real based on what those experiences were.
you just answered a good bit of a question I had, which was, let's see if you want to say any more, but could you put academic health center, healthcare, health education in the context of your vision for the university as a whole? I mean, you're trying to do a lot of things at once.
Yeah. And that's why, thank goodness, we have great leaders to be able to do that. So Tina hasn't heard me say this. Mark hears me say this all the time. You know, in my feeling of what my job is as your leader for this university is that there's certain philosophies that we need to follow. And one is that we have a long way to go and a short time to get there. So everything is urgent. I think that's what I tell my people to take breaks, because I'm always pushing them to say, it should have been done yesterday. Why wasn't it done yesterday? Having expectations for innovation and for growth. And so that's part of that Top Tier 2.0. Just understand too that that strategic vision, that came from UNLV. That didn't come from me. Now, I'm a fan of lots of pieces of it, but it really came from hearing people saying what was going on, what needed to go on, and what we thought we had the ability to do. And so that Top Tier 2.0 is, that entire thing is built off of that. I'm laughing to myself because as Mark was sharing about previous histories, because I am, let's call it officially or unofficially, still an active researcher. I have a research grant that I'm finishing up now, and it's related to health. In my previous institutions, I have typically had.
Isn't it health and basketball?
What's that?
Isn't there a basketball component to this?
That was one of my first publications was on basketball free throw shooting. See, I was a natural to come to UNLV, okay? No, it's on health and longevity in African Americans. That's what a lot of it's been on cognition. But in my history particularly at Penn State, at Duke, and less so at Wayne State because I was the provost, I had a piece of the health care settings, the university hospitals. And what I always make the point of saying is that for a lot of them, as somebody who studies mental health, they would have put me in the basement.
Yeah.
And I think that is a huge error, and it's one that when I look at some of those numbers, this is part of the reason why I believe that we can blow past some of them, is that we have a group of leaders that actually work together. And I'm jumping to another question of yours too, which is about how the academic health center, enterprise, whatever we want to call it, will work together. It's not going to just be the physical health components that Mark, I think, is very strategically thinking about which ones we should have for lots of different reasons. It's the idea that mental and physical health actually will be able to they'll sit side by side, but they'll integrate. And I've been at a lot of places that are supposed to be great places, and that could never happen, ever, 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 ever. I don't think that it'll ever happen. They will always be these very complete and very separate entities. I think we have an opportunity here to be extremely innovative, be one of a kind, because maybe it's the newness. I mean, I was listening to your talk and trying to figure out why do I believe that here there's a better possibility of doing that than any place else. And maybe it is the newness of that we haven't built up years and years and years of animosity between different elements of the health center, and so we can do that. But that's going to be one piece of it that I think is really going to make us unique. And the only other thing I would say is that Mark has been so helpful to me, because one of the things that I wanted to grow the day before I'd gotten here was the idea of research. Because I am, dyed-in-the-wool researcher, have been for a lot of years, and being at health centers that have a big research component, that helps to drive it. It drives the culture that's there. It drives what it pursues. It drives even, I think, sometimes how states actually look at those health centers. So, but I think he has corrected me enough that where we're starting at, we need to be more focused on what the community actually needs. And I think now that we've got a better feeling of that, he's a little more open to me pushing him towards how can we build the research component to it. I'm going on long because, see, I really am a professor. But I will conclude my remarks here, or for this section at least, to say that it's interesting. You were almost kind of doing the math of that. How do you get to a $50 million, whatever? And I've had several of our deans tell me the goal that I've set for us is they say very ambitious, and I'm like, no, it's not ambitious. It's that, guess what? If we build a great environment for people, we can go get 5 superstars, and they will put us in that other competitive realm fairly quickly. I think that one example that we have is Jeff Cummings. He's a perfect example of somebody who came here and has had an incredible impact. And he's barely been here longer than I have. And so, some of it's and it has so many other problems when you get a superstar, because everybody wants to be a superstar, but everybody's not a superstar. But when you get superstars, they create a culture and an environment that actually can build that capacity. And so rather than think about trying to go to the state and think that we're going to get, 500 new faculty members, we need to think more strategically about how we can get some superstars in strategic areas that can bring along the faculty who are there, that can influence them and create cultures within our academic health center that actually build that capacity. I'll stop there. Thank you.
A lot of amens from me if you were preaching.
Yeah, come on. Really?
Dean Kahn, if I could, Paul sort of gave us a roadmap, if you will, for an academic health center. By the way, congratulations on 2 weeks ago on the opening of the new building. But what have you done lately, right?
Right.
Where do you go from here?
Yeah, so when we think about academic health and an academic health center, it's a new concept for this region. So there's a lot of, we have to be evangelist about it to talk about what it is. It's not the medical school. That's a part of it. It's not the hospital, but it's that integrated network, right? We are here really to care for this community, right? So everything we do has to focus on the impact on the community. So when the president talked about research, we have to have research that focuses on a community need. And that's, whether that be aging, whether that be addiction, that's what the research has to be. When we talk about clinical care, we have to bring care to people, not people to care, right? So we have to change models, whether that be telehealth or mobile clinics or whatever. We have to figure out a model to do that. When we talk about education, we need to train the workforce of the future. We need to train people to be problem solvers, right? To see a unique set of, to be adaptive learners, to see a unique set of circumstances and be able to put that together, apply the knowledge they have to come up with unique solutions. And then when we think about community engagement, our fourth mission is getting out into the community. So what have we done lately? It takes a village, to borrow a statement, to do this. So what we've spent a lot of time on the past year and a half, and I want to just recognize Dr. Allison Netsky, our Vice Dean for Clinical Affairs, who's intimately involved in this, is who are our partners, how do we partner, and how do we use these partnerships to get from point A to point B? And that's really sort of what we're actively working on. We have right now an MOU with an NIH-designated comprehensive cancer center. Because if we were going to build that ourselves, it would take 2 decades. So the way to get there and the way to bring that care to the community that needed it yesterday is to partner. And we have an MOU also with Intermountain Health, who, they're leaders in patient safety and quality, and we want to work with them, again, to not only train the doctors of the future, but to provide the very best care. So what have we done lately? It's establishing these partnerships, establishing priorities, figuring out how we get from step A to step B. That's what we're doing.
And if I could, just to add to that, because I'm such a fan of Dr. Kahn and how he has tried to navigate the start, because, it's one thing if it's been running for 150 years, but it's another thing to start something. And I think what he was saying about the partnerships, what I really like about what he does, and that he always communicates back to me, is that it's about shared values. Because healthcare is something, these are people's lives. Their life is at stake. And you want to have partners that share the same values as you have. And he started with the values that the medical school has. that the Academic Health Center has, and that making those kinds of partnerships usually make things go much more easily than trying to say, well, you do this, but we do this, but we argue this, but you'll spend all of your time doing that rather than coming together. I think that's been true for Intermountain Health, for example. That one's the most obvious example that I know of, but I think that that's a critical piece of it.
Tina, let's turn to you and say in your first few months, are the leaders of your organization, your board, your staff, is the healthcare sector?
Something we talk about?
Yes.
Something that's on their minds. So it's interesting. Yes, at the policy level, at the board level, quality of healthcare is very much top of mind. The things that I've heard from our board members who are in the healthcare industry are the ability to, they need our help, our community's help as much as possible to recruit and retain providers. And to some extent, that just means making sure that the recruiters understand the quality of life that we do have here in Southern Nevada, that it is more than just the Strip, because you're trying to attract not just the provider, but also their families. So making sure that they understand that we've got access to outdoor activities, that we've got, we do have some quality schools in Southern Nevada. Emphasize on the some, because we are challenged. Emphasize again, the quality of life beyond just the Strip. Being able to grow and attract a diverse workforce, or be able to have a trained workforce, diverse workforce within Southern Nevada that they can draw from, and that requires a lot of these partnership efforts that Dr. Whitfield is working on with our other higher ed presidents, to make sure that we are addressing kind of at a surgical line item level, what talent do you need, what degrees, what certificates do you need to support this particular area of healthcare. We talk about incentives, the fact that the states, other states offer incentives to get talent to move into their region, whether it's through paying for their student loans or giving them cash incentives. That is not something that is in our buffet of offerings. To stay competitive, to attract that talent, that's one of the conversations. And then, of course, other things that Paul talked about, increasing the number of residencies, and the fact that we do truly need to fund our system. We have a state that I think on average pays about 30%, reimburses at a 30% rate for Medicaid, and that puts us at a challenge for truly attracting and retaining providers. Those are the types of things that I hear about in our conversations.
Let's talk a little bit about residencies. I think we're statutorily required to talk about residencies at every health-related meeting, but, and congratulations on the numbers there that showed just in 2 years what contribution the school is making. I know the governor's office announced that they have some money directed toward increasing residencies. Just yesterday, the Southern Nevada Forum identified increased funding for residencies as a priority going into the next legislative session, and it'll be here soon. So if you're going to increase the class size to 90 and hopefully 120 eventually, these students need to have residencies here or we lose them, right?
That's right. So the numbers are that if a medical student graduates from a school in Nevada, it's about a 50-50 chance that they'll stay here. If they do residency here as well, that goes to about 80%. So the residency programs are critical. That's how we get people to stay here. To put things into perspective, CMS, the Centers for Medicare and Medicaid Services, fund most residencies in the United States. We have 403 funded spots for the entire state. The state of New York has almost 20,000. Granted, they're bigger than us, but the ratio isn't even close. How did we get here? Well, we had one relatively small medical school for many, many years, and residency funded positions by CMS were frozen with a bill passed in 1996. It went into play in 1997. And I would argue we're a very different state now than we were in 1997. We have a long way to go. I do applaud the governor's office for funding residencies, but we need to understand those are pilot grants. So initially they funded 2 years, now 4. So after the pilot grant's over, we have to find a way to fund these residents. Our principal partner, UMC, it has about 50 more residents than they pay than they get reimbursed for. Those numbers will get worse as we expand residency positions. So we really need to have a national discussion on parity and equity in residency programs if we're going to get where we need to be. I applaud the governor, I'm happy, but we got to remember those are pilot grants, and we have to find a way to fund these positions after that.
President Whitfield, there's always discussions about Nevada and its relation to the federal government and getting our share of money back from the federal government. Paul talked about research funding and trying to build that up, and particularly NIH relating to health-related research. The university have any plans in that regard?
Yes, on about 100 different fronts. One front I can say, actually, Dean Kahn and I were just talking about it when we were sitting in the audience, is that one of the buildings that we want to build is an interdisciplinary sciences building. And part of the people that we would think would inhabit that building would be academic health researchers, making sure that they have, 21st century facilities to be able to carry out their research. As I've been funded for like 25 years or something like that, but I mean, as a continuously funded researcher who's done reviews of grants, one of the biggest critical pieces to grants that it's funny, it's not as prominent as it used to be, but it's still in there, is actually your capability to do the work in the first place. And so that usually is seen at least two different dimensions. One is who's there? And so again, my interest in trying to attract some superstars, make it look like it's on the map. Like, because Jeffrey Cummings is an aging and I'm a gerontologist, and actually I was on the National Institute of Aging's National Advisory Board, and people came to me, the president of the university, and said, "Do you know Jeff Cummings?" And I was like, wow, he's a bigger star than me. That was a big deal to get him here. So that's one piece of it. The other piece of it is facilities. And I think that the medical education building, I don't know about you, I'm hearing from colleagues all over the place saying, hey, bravo on the medical education building. I was like, well, I wish I would have done some of it, but yes, we're very, very happy. But those kinds of capabilities are part of the formula to be able to develop and expand a research portfolio. One of the other things that I'll just mention is that one of the things that we have done is I charged the provost with creating an interdisciplinary research program. And it has two components to it. One component is that in terms of hiring, that we just got the ability to be able to hire. And so you hire around, there's 6 ones, but just don't hold me to knowing which ones they are. I can't remember the names of them. But there's 6 interdisciplinary areas. And I can tell you that most of them tend to be kind of health related. The other piece of it is that we have people on the ground actually doing some interdisciplinary research, and that we need to put little bits of money behind them to give some pilot grants to get them going, because for both of these things, it's the idea of creating a culture here that is interdisciplinary, and that part of it is around the health, biology realm. And again, out of those 6, I'd say at least 3 of them kind of match that piece. So those are just 2 things.
Another thing that happened at the event a couple of weeks ago, Dean Kahn, was the announcement of $70 million for 2 more facilities, literally across the parking lot from your new building, as well as the designation of the area as the Las Vegas Academic Medical District. Can you talk about what those 2 things mean? And Tina, you may have some thoughts on that as well.
So, sure. So we're very thankful to the governor and the legislature for approving money for a new ambulatory building. And as President Whitfield talked about a little bit ago, this is a somewhat unique concept. We want to take care of the total patient, so we want to combine medical and physical health in a single space. And as we've been planning, I see Michelle Paul and Sarah Hunter in the audience, and there are representatives for behavioral and mental health, and Allison Netsky actually is a psychiatrist as well. But what we don't want to do is we want people to get the care that they need. We don't want to stigmatize mental health. So we want to try to provide that care for everybody in an equitable fashion in the same space. We also got an additional $30 million to work with our partner UMC in to build a new laboratory building, including hopefully some research space.
Wait, do you mean the new UNLV Medical, rebrand UMC as UNLV Medical Center?
That's different.
Oh,
That's different. We'll talk about that in a minute.
so I'm
And
excited
then-
about that one.
What's that?
I'm excited about that.
We'll talk about it. So, I mean, that would be great, but they have to agree to do that, right? It takes two to tango. And then when you talk about an academic health district, I think for a couple of years, we've been talking about how to fund uncompensated care and how to fund some other things that we've talked about, even residency programs. So if we could get a special district with a special tax, other academic centers, other cities have done that, that would be a good way for us to get some of the resources we need. You know, our mission is to care for the community. We don't turn anybody away, but we can't go broke doing that either. So we need to have a way to help support that mission. And an academic health district might very well be the way to do that.
And I hope to, please let Tina speak. I apologize, but I will let Tina speak. But I just wanted to make the point of, you know, sometimes as we've been talking about the health district, I think people think that that's the only place where stuff's going to happen. It's like, no, no, no. That's just the jumping off point. One of the things that Dr. Khan worked tirelessly with CCSD to do was to put a clinic in an extremely needy area in an elementary school. And so far, so good. I know, Allison, it's very new.
Allison.
Yeah. No, it's very new.
Yeah.
She doesn't even like, I think, to talk about it because it's like, let it get its legs first. But that's one outcome that comes from the strength of having a great medical school, working with partners. But I tell you, the funding for it has been, I think, there was a lot of sweat rolling off of Dean Kahn's head trying to figure out exactly how you do that, because it's something that it's basically coming out of creative financing is what's happening. But because it was such a need, that was a response that was able to be made. And so it's a perfect example of why that health district is going to be this great jumping off place to do other things throughout the community.
Yeah, I would just amplify that, and certainly as the Economic Development Agency, we are always looking at grant opportunities from the Economic Development Administration, and certainly having this district kind of gives us some gravitas as we go to apply for some of the grants that we'll be searching out for.
Great.
And as far as rebranding UMC, that's not our call.
Oh, I know, I just,
That's why we pay consultants. We brought in mental health a little earlier. And Tina, if you were happily surprised that we were fifth and not last, I can bring you back to reality and say,
yeah, we're last. It's in terms of the number of dollars allocated towards per capita
it's
towards
a
mental health.
tough problem with a
Yeah.
lot of challenges, but something
Yeah.
an academic health center might be able to help address. Mark?
Oh,
Yeah. Oh, no.
Oh, so yes, so again, you know, when you look at cities that have well-developed academic health centers, you know, they provide the type of care that you need. We, you know, are training the next group of healthcare professionals. And again, these aren't just physicians. I want to make, you know, we have psychologists and we have psychology training programs. We have social workers. We have nurses who work in the mental health field. So that sum total of academic health contributing to that workforce, I think is really something that academic health brings to a community that might otherwise not exist there.
And it's I don't know if this is anecdotal or not, Tina, but when we're talking about economic development and bringing businesses here or recruiting businesses here, it always was education and healthcare as the top two.
Workforce. First is workforce. Where am I going to get my workforce?
Right.
And then is actually transportation is up. So when you talk to site selectors or those companies those professions that specialize in relocating companies, generally is workforce, transportation, utilities, education is up there, and then healthcare.
And I can only imagine that's going to continue and even be exacerbated in a post-COVID world, right?
Yeah, absolutely. So, I mean, we don't come right up. So here's something that's kind of interesting I shared with Paul earlier is when a company's coming to or talking with us about possibly relocating, If it is a company that doesn't plan to actually move their C-suite here or their headquarters, if it's a company that is truly just looking for employees, they don't ask, or they're just gonna have employees here, they don't ask about education or about healthcare. Now, if it's a company that, and those are the lower skill, lower wage jobs. If it is a company that is higher skill, higher wage, and plans to move their headquarters or their C-suite here, all of a sudden, kind of everything flips, and education and healthcare are top of the list. Workforce is important as well, but they really want to know about healthcare, education, and healthcare. So we are trying to kind of put in our quiver, arrows, points that can help them understand how we do have some gems in healthcare. In particular, we are now really starting to, of course, the School of Medicine, and the fact that we've got this new academic center, and this new news that we've got this academic district. Also that Toro is growing their classes. We've got Roseman that is growing their classes, and the types of professionals that they're producing. The Helios Medical Health and Wellness Medical Campus that'll be up in North Las Vegas. North Las Vegas doesn't have a hospital. So people who have to live up there, and a lot of our economic growth is up in that area. They have to travel outside of their own city. So the Helios campus, I don't know if Terry Sheridan is in the audience or not. Terry, thank you. Way back there. Yeah, from North Las Vegas, but I was talking with them. I mean, it's gonna have 600 beds. That's just a gem to bring. So there are things, we've got some arrows in our quiver now that we're starting to talk about as it relates to their concerns for healthcare. So thank you to the people in the room and people on the panel.
Thank you all so far. This has been fascinating. The level of sort of excitement and interest, you all recognize the opportunity that's there, and that there's this potential in this community.
We didn't even talk about like sports medicine in terms of economic development.
Right.
Sports medicine is this huge thing. I was looking at the statistics. There are 11,000 professional athletes, but there are 45 million, young youth athletes. All of it, that is just a huge burgeoning industry that's supposed to double by the year, I think it's 2036 or something. I mean, it's just huge. So as we are growing our strength, our presence in this sports world, that type of medicine is probably going to grow organically, and there'll be more demands from.
It's high in our strategic plan.
Yeah.
No, we recognize that as when you look at unique economic potentials, that is clearly.
So you look,
Way up
and we're going to be part of this number 6, promote a bold and transformational regional strategy. I can't wait. I look forward to that one.
Right there. That seems like the perfect symbiosis there. If you have a university with strengths in fields like kinesiology and nursing and others to work together. I know you spent a lot of time in bringing people together for the Build Back Better grant, Tina, and had that experience of bringing all the different municipalities in the region together at that level, and you actually had some success there in getting that grant into the final category. But can that be applied to the healthcare economy as well?
So you're asking, is this type of partnership between the academia world, the philanthropy world, and private sector world, and hell to the yes. You're not. I don't know if that's appropriate, but what just happened here with the philanthropic effort that went into making this school happen and this facility happen, and the partnership with UNLV, that's a really big deal. And I have no doubt that has kind of upped the bar in terms of collaboration on when we got to get it done. We are going to sometimes need to turn to private sector and philanthropists to help us just cut through ourselves and get it done.
I didn't see Maureen Schaefer here. I don't know if she is, but
Out of the country.
Oh, that's a good excuse, I guess. But from the Nevada Health and Bioscience Corporation, who led the effort on the medical education building, and the governor's asked them to do the same on the next buildings there. So that this public-private partnership and philanthropy playing a key role, but it now has credibility with legislators, with the general public for having a track record of doing things. So
Everybody wants to say they were a part of it, right?
Where we sit, anybody can take credit as long as it gets done. Right?
Not something you always hear in academia, President Whitfield.
Oh, no, you're
Okay. Paul, I'm going to give you an opportunity to ask our panel a question.
I just want to say to the panel, what a great job you all did, but also how many things that you're talking about turn the ideas into action and impact. And as I think about what you've all said, and I think about the big question is, what can it be? You're following a new roadmap with new people. Tell me in your mind, what do you see in 2040? Give me something that you see what this can be, because you're following now a pathway to success that I don't think we can even imagine.
I think by 2040, we really need to be able to provide exceptional care for our community. The thing that keeps me up at night is that bad joke about the airport that I won't tell.
I hate
that
that.
keeps me up at night. And it's our responsibility, it's on us to fix that, right? So by 2040, I don't want to hear that joke anymore, right? I don't want to hear it even sooner than that. But we have to have a level of care that this community deserves. That's quality, but it's also access, it's affordability, and it's the spectrum of what we offer. I mean, look, we don't do liver transplants in this state. We don't do bone marrow transplants in this state.
I gave my son a piece of my liver, but not in this state. I had to go. I went to
Thank
McCarran
you,
Airport.
but yeah, but we need that here. We're a population of 2.5 million. I'll tell the joke.
The biggest healthcare system in Nevada.
Paul, that's what keeps me up at night. But that's
That's a joke, folks.
yeah. But that's what I see with academic health. And I didn't recognize Dr. Dina Mars in the audience too. I mean, nursing. We know about a national nursing shortage. We are training nurses, but we need to train nurses that can practice in the future, and that's what she's doing. So I want to see us be a model for care. That's what I want.
I want to talk about something else that's coming into my conversation points as well that didn't exist before. And we have a pretty strong presence in Intermountain Health, which is a true not-for-profit healthcare provider. And just anecdotally, this is a big deal, and that they're here now. And I knew it when I'm going to share some stuff confidentially. So I really tried to get out in the community and meet different people when I took this position, in particular those that were responsible for our larger healthcare systems and providers here in Southern Nevada. I went to lunch with Intermountain Health, and he talked about the fact we were the worst health, the state of the state here, and their thoughts about how we change it. And they talked about just care and the types of services that we were missing here and how they wanted to help integrate. It was all about trying to really shift and move the needle of healthcare here in Southern Nevada. And then a few weeks later, I went to lunch with somebody else who was overseas. It plays a significant role in another large healthcare provider. And it was all about money. It was like, well, here's where our profits were last year. And as a result, I brought in X number of sales. And as a result, our unit is going to earn this much. And I thought, wow, what a complete contrast.
So Tina, Paul and I had dinner. We have dinner often, but we had dinner Sunday night. And, part of the academic health center is, and I'm going to show a bias here, but it's bringing those not-for-profit partners together. The not-for-profits have a different outlook, right? We don't have shareholders that we need to satisfy. And I see part of this academic health network as bringing those pieces together. Intermountain being a critical part of it, but we have a not-for-profit health system with common spirit. So we talk to them all the time as well, and it's bringing those pieces together. UMC is our major partner, again, a not-for-profit. And I think that's where you're gonna see people who are more willing to not look at, to simplify, as a not-for-profit, I can wake up in the morning to break even, right? I don't have shareholders. And, I think that that's, going to be critical for our community moving forward.
was going to say, let me take a quick stab. So, well, I was going to say, I have to stick with my crazy little statement. We got a long way to go in a short time to get there. I don't want to wait till 2040. I want to wait till 2030. To me, that's what I see. And I agree with the sentiments that were added, but I would add that thinking, I'm playing to the crowd too. My mother's a nurse too, so I'm always very deferent to our nursing. But that's, we can talk about the medical center, but we have to talk about the people in the medical center. Sometimes we only think about physicians. And it is going to be the other parts and pieces that have to be brought together and to fill around, and that I think it can happen by 2030. One of the programs that nursing runs, for example, is this really cool summer program for kids in CCSD to come. And it's cool because they're not real, they're rubber, but they look real. They actually get to touch and to do, and it's experiential learning. We need to have 4 times that many summer programs and summer experiences. I'm thinking about our perspective as a university of what we need to do to make that real. We've got to work with CCSD and provide any support that we can to be able to make sure that we increase the number of college-going students, because without them, there's a little bit of challenge there. I think the other piece that I think that we'll grow as a university is actually bringing folks from outside in. And part of the way we'll do that is that this is, to me, Vegas is already the place to be, but really showing that we've got healthcare dealt with. We're working on our workforce and diversifying it in very interesting ways. And again, the university is there and a primary piece to that. And also being able to have this world-class education that you can get here. And I believe we already have one. My biggest struggle is that I don't think enough people know about it. And so we are working now to even try to expand our reach digitally. Both Southern California and see, I'm still in that professor mode. I want to lecture to you. I wish I had some slides, but and the part of the numbers that I was thinking of is the idea that I want to see us get to 40,000 students. We're at about 31 now, to get to 40,000, and some of those are growing students that come from our state and growing the college-going students coming from out of the state. And part of the numbers there are that in the future, there's going to be a demographic cliff in 2026 where after the downturn, people stopped having as many babies, and so you see fewer numbers. Well, guess what? You don't see that in the Southwest. So we could easily be one of those forces in the Southwest, and there's other schools that do it too, but if we design ourselves to be that force, you build it and they will come. And then the other piece is international students, because part of, I think, what makes workforces healthier, better, is diversity. We're the second most diverse campus in undergraduates in the country, and we need to keep that diversity going, and part of it being international. And I do sound like your president, that's good. I was gonna say, I'll end on this point to say that of all the things that we're talking about, actually diversity is one of the critical pieces of it, because what it means is that you have doctors that, like you were saying, that are going into areas that need help. Or I'm a health disparities researcher. I want to see us do more health disparities research to address the kinds of things that are going on right in our own backyard. But that diversity actually I think it makes you a better physician, better nurse, better public health person, because you start to understand difference. When you understand difference, you can be a more caring person, you can be a more thoughtful person, you can be a more understanding person, or doctor. And so that's one of the things that is a value of this university. And if we can continue to grow that, I think that 2030 landmark of really being able to be even a greater force in this area, in this country, I think will be there. The last thing I will say, I promise, is that I am still so connected with the intersection between physical and mental health. I think that it has been a huge problem for healthcare. We keep talking about healthcare, specifically healthcare, about the quality of healthcare that's actually given. It's because those two things are thought of as two separate things. I think our plan here is going to make us, we'll look at your numbers and that if you get a quality index or something like that, we're going to go past it, because we're going to have intersected those things between interprofessional education, between medicine, nursing, PT, OT, all of those things of coming together and working and talking, and physical and mental health. That's what's going to be, I think, part of the game changer, and hopefully past 30 will help us to grow, expand.
Well, I've done a few of these events, and I think leaving the president the last word is always a good idea. But we couldn't have had a better last word. Thank you. And thank you all very much. Before we leave, though, I want to invite colleague David Demore back up to say a few closing words.
Thank you, Bill. First of all, I want to thank everybody for attending, thank our wonderful panel, thank Caitlin and Ashley and our student workers for putting this all together. Just kind of sort of listening and thinking about our discussion here. A couple things obviously about it. Thinking about it a decade, right? Relatively short period of time, you see how far we've come. This, a year ago, a decade ago, this was never going to happen, right? There were so many forces against us, and to see us get to this point there, but also seeing the opportunities in front of us. I think President Warfield sort of hit it on the head. It's like one thing the strength we have is we're not trapped by our history. This is all new. We get to reinvent it. You look at that building, it's the building of the future. We're not building the building of the 1940s medical education, it's of the future. So I think that's very, very exciting. I think having the Academic Health Center to pull all these parts together is going to be very, very, help move the needle much, much quicker there. So we don't have to wait 10 years to have Paul come back to the next step. We can have him in 3 or 4 years back and say, look at you.
Because I'm getting old. I don't know how many more years I have at 60 years old.
You'll come back for us.
Well, the next meeting in Philadelphia.
The second is there's clear momentum, right? There's clear momentum here. You see if you go down to Las Vegas, down to the medical district, something new will come up all the time there, and I'm excited for these new buildings coming along here. I'm particularly excited about the Development Corporation. We now have an entity that's able to take money from the federal government, state governments, local governments,
Huge.
and philanthropy, put that all together, and to do it outside of the sort of restraints of the state. And we saw how quickly they're able to get that building up and get it at a lower cost. Oh, thanks. All right. That's okay, thank you. So that's very, very exciting there. And then, of course, the big point here is healthcare is economic development and diversification, right? Everybody wants to chase the new tech thing, something new and shiny. We just need to stop exporting our healthcare. That'll help us grow our economy. It'll also bring in high quality jobs, a better workforce here. And I think there's other things to think about as part of that. Tina mentioned the ability to recruit companies here. That might now not come here. They might go to Phoenix, they might go somewhere else, right? If that's a barrier, we need to overcome that there. I think there's also other parts. Go down to downtown Las Vegas, you're gonna see a new downtown essentially being built there. And that means infilling, that means all this sort of downtown that I think a lot of people like to see here, knowing that we're landing on a land that we need to start thinking more strategically about how we develop and where we develop here. So I'm very, very excited. Again, thank you everybody for coming out. Thanks again for our panel.
Yeah, thank you.